So in the section about myocardial infarction, we talked about cardiac dysrhythmias, also known as arrhythmias, being one of the side effects of myocardial infarction. So we're going to talk in this section about cardiac dysrhythmias, what they are and how they're treated. So really all that's meant by dysrhythmias or arrhythmias is deviations from normal cardiac rate or rhythm. And they can be caused by electrolyte abnormalities. So we know that potassium is one of the biggies in electrolytes for cardiac function. They can be caused by fever, hypoxia, stress, infection, drug toxicity, myocardial infarction, as we talked about earlier. Electrocardiography monitors the conduction system and detects abnormalities. So when you have cardiac dysrhythmias, they reduce the efficiency of the heart's pumping cycle. So a slight increase in heart rate increases cardiac output, but if the heart rate is too rapid, it prevents adequate filling of the heart during diastole, and it can interfere with the normal filling and emptying cycle. So there are many different types of abnormal conduction patterns, but we're just going to talk about the most common ones. So this is an ECG strip, and these PVCs, it doesn't stand for polyvinyl chloride, it stands for premature ventricular contraction. So instead of our normal cardiac rhythm, we have the ventricle contracts too soon, meaning it's not sending out as much blood because it fills and then it contracts. It fills and then it contracts. If it contracts too soon, it doesn't have enough blood to shoot out into the arteries. So premature ventricular contractions, they're one of the dysrhythmias that an AED is going to detect and then try to give you the shock to prevent that. So the treatment is pretty much the same for most cardiac dysrhythmias, is determine the cause. Sometimes they're going to use medications. Sometimes it's caused by the medications and they need to change the drug dose. There are some different types of anti-arrhythmic drugs that they use. Beta-androgenic blockers, calcium channel blockers, and digoxin, which we talked about in a previous section. A lot of times those are used for preventing arrhythmias. If an arrhythmia cannot be kept in check by medications, a lot of times someone needs to get a pacemaker implanted. So one of my friends was having problems with cardiac arrhythmias. She was having some atrial fibrillation, which is called AFib for short, and a few other dysrhythmias. And so they tried some different medications, which were not very effective for her. Then they tried her out with this little defibrillator vest. So you can take it off, it's not implanted. She had to wear the little vest, and it has a little suitcase attached to it that has its mechanisms, and carried around with her everywhere. And they had to determine if that was doing the trick. And once they determined that that was doing the trick, then she went in for surgery and had the pacemaker implanted. But with that little vest, she had a name for it. I can't remember what she named it, but she was allowed to have it off for an hour every day. And for most people, they would take a shower or something during that hour that they had it off. She's a retired yoga teacher, and so during her hour that she had her pacemaker vest off, she would practice handstands. So, to each their own. But now she has a pacemaker, she's doing fine, and she's in her 70s, she's still doing her handstands. So you gotta love the woman. So the most common type of abnormalities is what we're going to talk about. Sinus node abnormalities. As we know, as we discussed earlier, the sinoatrial node is the pacemaker of the heart. So if the sinoatrial node isn't working, then you need that mechanical pacemaker to do it. So the different terminology, bradycardia means a regular but slow heart rate. And we know that what's considered the normal range for heart rate is 80 to 100 beats per minute. So bradycardia is going to be slower than that. Tachycardia is a regular rapid heart rate, so faster than 100. And that's just at rest. Sick sinus syndrome, is marked by alternating bradycardia and tachycardia. That is often one of the clues that somebody needs a mechanical pacemaker when they have sick sinus syndrome. So with your sinoatrial node, we talked about this in the first part of the chapter, it's the thing that's sending out the first signal that tells your heart to beat. And it sends it down those Purkinje fibers. So if your sinoatrial node is not working, then you need that external help, or you need that mechanical help. A lot of times when somebody's on their pacemaker, and you'll learn about more of this when you talk about cardiac rehab, but a lot of times the pacemaker will keep you at a pace of 60 beats per minute. I was working with a lady the other day, and she has a pacemaker, but she was coming in working on a couple other things. But that is just part of her medical history. We know she has that pacemaker, and she goes, yeah, I'm a little tired today, and I can feel my pacemaker kicking in. So when we took her vitals partway during the session, her heart rate was right at 60. And that is, to me, when I see that 60 even, and it stays that way throughout the session, that's a pacemaker heart rate. So that's just one of those things that you learn when you work with a lot of cardiac patients. Kind of interesting. So here's what a pacemaker looks like. You know, it's like the phantom view, so you can kind of see what it looks like. And you can see when somebody has a pacemaker, they usually have a little incision on the front of their chest, and you can feel the pacemaker under it a lot of times. And that pacemaker, its wire goes right into the heart, and it takes over when the sinoatrial node is not doing its job. So these are from the book ECG strip recordings. So the first one, A, that's a normal ECG. B is a AV node block, very slow ventricular contraction. P waves widely separated from peaks of the QRX complexes. So it looks different from the good one, doesn't it? Bradycardia looks just like the good one, but it's faster. But it's slower, sorry. Tachycardia, it's faster. Premature atrial contraction, and then we looked at the one with the premature ventricular contraction in the other slide. Atrial fibrillation, you just get all that atrial stuff going, and ventricular fibrillation looks very disorganized. Very kind of interesting. You know, of course, as PTAs, we don't have to read EKGs, but it is interesting to know what's going on with them when you see that. Also, if you ever have the occasion where you have to use an AED, you'll know what it's talking about, which is kind of nice. It's nice to be in the know about this stuff. So atrial conduction abnormalities are fairly common. So you can get premature atrial contractions or beats, and sometimes they'll call them PACs or PABs. There's an extra contraction. So the atrial muscle cells are described as being irritated. So it's not the normal, the atrium contracts and sends the blood into the ventricle, then the ventricle contracts and sends the blood into either the pulmonary artery or the circulatory, the aorta, depending on which ventricle. With extra contractions, you get these extra atrial beats. So basically, the atrium's contracting when it's not supposed to be, when it's not all the way filled up. So atrial flutter is considered an atrial heart rate of 160 to 350 beats per minute. So the AV node delays conduction and the ventricular rate is slower. So what happens is the atrium doesn't fill up, and so it's pumping out little bits of blood, then the ventricle doesn't fill up. It's a bad situation altogether, so they want to do something about that. Atrial fibrillation is a higher rate. It's over 350 beats per minute, and it causes pooling of blood in the atria. And there's a risk for forming a thrombus with the pooling of the blood, and then we know that thrombus can break off and go to the brain and cause a CVA. So atrial fibrillation carries with it a higher risk of CVA or stroke. So you can get what's called a heart block, which is where conduction is excessively delayed or stopped at the AV node or the bundle of His. A first-degree block, there's a conduction delay between the atrial and ventricular contractions. A second-degree block, every second to third atrial beat is dropped. So you're missing atrial beats, and that's when you get the pooling of the blood in the atrium. A third-degree block, there's no transmission from the atria to the ventricles, so there's no coordination of the contraction. So and you do not have to memorize this, just it's another nursing thing that I think is cute. And it's the heart block poem, and it's how to tell which level heart block you have. And the Wenkenbach and the Mobitz 2 are the second-degree blocks, or levels of second-degree blocks. So it's just cute. You don't have to remember it. There it is. So ventricular conduction abnormalities, the one that you see probably most commonly is a bundle branch block, and there's interference with conduction in one of the bundle branches. So those are the bundles of His, and they're getting the message from the AV node that's telling the ventricle when to contract. So the ventricle's not contracting properly. Ventricular tachycardia reduces cardiac output because you get reduced diastole, meaning that's the filling time, the resting time. And so with ventricular tachycardia, it doesn't get to fill up as much. Ventricular fibrillation, just like atrial fibrillation, the muscle fibers contract independently and rapidly. They're not in rhythm with the rest of the heart. And the cardiac, you can have actual cardiac standstill where the heart stops if ventricular fibrillation isn't treated immediately. So premature ventricular contractions, or PVCs, they're additional beats from the ventricular muscle cell or an ectopic pacemaker, and they can lead to ventricular fibrillation, which can cause your heart to stop. So some of the ventricular conduction abnormalities are serious medical emergencies. I mean, really any conduction abnormality is a serious medical emergency, but particular ventricular. So this is the chart from the book on page 244 that has the cardiac dysrhythmia, some terminology, the bradycardia and tachycardia, and the effect of that. So with bradycardia, slower than 60 beats per minute, stroke volume is increased because you get that pre-fill, and possibly reduced cardiac output because you're just not beating as much. Tachycardia is too fast, over 100 beats per minute, between 100 and 160, and you get possibly reduced cardiac output because you're beating too fast. You're not allowing the heart to fill up in between beats. Fibrillation is the rate over 300 per minute, and you get uncoordinated muscle contractions, no filling, no output. Your heart stops. Premature ventricular contractions are those additional ventricular beats, and they may induce fibrillation, which can then cause your heart to stop. The bundle branch block is delayed conduction in one bundle branch. So it doesn't have an immediate effect like the fibrillation, but it's something that they are then going to look at to be treated later. So they have the heart blocks, the first degree partial, the second degree partial, and then the total heart block. So the first degree, it delays conduction in the AV node, and it doesn't have an immediate effect. The second degree and the total heart block have decreasing cardiac output, and they can cause you to faint. They cause syncope. So cardiac dysrhythmias can be very serious and lead to cardiac arrest. So the way they're treated is they have to determine the cause. What's causing it? They usually, in most cases, those drugs are effective. If you have sinoatrial node problems or total heart block, then that requires the implantation of a pacemaker. There's also an indwelling defibrillator, which may be implanted, that can convert ventricular fibrillation. So if you have continuous problems with ventricular fibrillation, they may implant, sorry, install is not the right word. They may implant an indwelling defibrillator. So when that indwelling defibrillator detects that you're having ventricular fibrillation, it zaps you right then and resets your heart, basically. So one time I was working on the cardiac floor in the hospital with a guy who just had an ICD, indwelling cardiac defibrillator, implanted. Sorry, I want to say installed today. He had just had it implanted. He was doing really well with his rehab. He was getting ready to go home, which I love working on the cardiac floor because most of the people on the cardiac floor are going home. We're getting them ready to go home, and they're doing really well. So it's a great place to work. Either that, or they're doing really, really poorly, and they're not appropriate for PT. So the ones that PT gets to work with, they're usually going home. So I had worked with him one day, and he was telling me how much he was looking forward to going home and walking his little dog, and he showed me pictures of his dog, and it was great. So the next day, he was scheduled to discharge from the hospital, and we were going to do some exercise, we were going to do some PT treatment, and I went in there, and he says, well, you know, as soon as we finish PT and maybe a couple other things, they're going to discharge me, so is it okay if I take off the hospital pajamas and put on my regular clothes? And I said, sure. So he starts getting dressed, and he was going to stand up and put his pants on, and I said, why don't you sit down to put your pants on, just to be safe? He says, okay. So he sits down, and he takes off his little hospital pajamas, and he goes to put his pants on, and all of a sudden he had this really funny look on his face. And I'm like, are you okay? And all of a sudden, man, and he was still on telemetry. Every alarm in the place went off, and a million doctors and nurses ran into the room, and he was going into fibrillation. And then one of the doctors said, oh, his defibrillator's about to kick in. Zap, it did, and he was fine. He was a little disappointed, and they kept him for another day, but then he did get to go home with his little dog. But I was so glad that I asked him to sit down before because if that had happened while he was standing up, putting his pants on, he probably would have fallen. But luckily he was sitting down. So they had to adjust the indwelling defibrillator a little bit to make sure that it was not letting him get to that stage before it kicked in. Interesting. So cardiac arrest is cessation of all heart activity, no conduction of impulses, flat ECG. So lots of reasons can cause for cardiac arrest. Excessive vagal nerve stimulation, that's our cranial nerve number 10. Potassium imbalance, we talked about that previously. Cardiogenic shock, drug toxicity, insufficient oxygen, respiratory arrest can then cause cardiac arrest, or a physical blow to the heart, like trauma. So cardiac arrest is, that's a 911 call if I ever heard one. That's a do CPR call while you're waiting for 911 to get there. So in the next section, we're going to talk about congestive heart failure.